Hey, BC here for BC Nephro. I'm Dr. Brian Cronin, board certified nephrologist and clinical specialist in hypertension. Today I'm going to be talking about thiazide diuretics and why I believe chlorthalidone is better than hydrochlorothiazide. For more information on diuretics in general, check out the video at this channel and the article at bcnephro.com. I'll have links to both in the description below. But now let's get into it. Thiazide diuretics are often used in the treatment of hypertension and kidney stones, nephrolithiasis, particularly if there is hypercalciuria, and my go-to is chlorthalidone. Now, chlorthalidone has a longer half-life than hydrochlorothiazide. The half-life of chlorthalidone is about 40 to 60 hours, where the half-life of hydrochlorothiazide is only about 6 to 15 hours. In addition, chlorthalidone is more potent than hydrochlorothiazide, about 1.5 to 2 times more potent. When studied head-to-head, most often 50% of the dose of chlorthalidone was compared to hydrochlorothiazide to take into account this difference in potency. Despite this, studies have shown better nocturnal and 24-hour ambulatory blood pressure monitor with chlorthalidone, which is not surprising given the longer half-life. The improvement in nocturnal or 24-hour ambulatory blood pressure may be mitigated if the hydrochlorothiazide is dosed twice daily as opposed to once daily at the higher dose. And in general, there was no significant differences in daytime blood pressure. A more recent study in the New England Journal of Medicine, for which I'll put a link in the description below, compared hydrochlorothiazide to chlorthalidone in this way and evaluated for cardiovascular outcomes. What they found is that using 50% of the dose of chlorthalidone did not result in less cardiovascular events. In this study, the mean systolic blood pressure was about the same, about 139 throughout the study, and it's not surprising that using a medication to target the same blood pressure, you would not find a difference in cardiovascular events. However, this does not mean chlorthalidone is not better and that it is not more effective for controlling blood pressure. Chlorthalidone typically is not used at 50% of the dose. Hydrochlorothiazide is most often used in a 12.5 to 25 milligram dose and is only rarely increased to 50 milligrams a day or more. Chlorthalidone is often used at 25 milligrams itself. In fact, the generic form does not come in a strength lower than 25 milligrams. In my patients who do not tolerate this dose and require a lower dose, they have to cut the pill in half, or sometimes I prescribe 25 milligrams every other day. Now, what about metabolic side effects? Now, chlorthalidone has been said to have a higher risk of metabolic side effects, the most common being hypokalemia. When using the 50% dose, most studies have not shown a significantly increased risk of metabolic complications. The study that I just referenced did show a higher rate, 6% versus about 4.4%. You would think that if you use the higher dose of chlorthalidone, 25 milligrams, you may have a higher risk of hypokalemia as compared to 25 milligrams of hydrochlorothiazide. But in my clinical practice, this is not prohibitive. I do not commonly see severe hypokalemia less than 3. This may be because many of the patients are also on renin-angiotensin system blockers, which may mitigate the hypokalemia. In either event, the potassium does need to be monitored closely. My practice is to check it within 1 to 2 weeks after initiating either of these medications or increasing the dose. What about the use of chlorthalidone in more advanced stages of chronic kidney disease? There was another study that I'll also link in the description below that evaluated the effectiveness of chlorthalidone for uncontrolled hypertension in patients with stage 4 chronic kidney disease. It traditionally had been taught that thiazide diuretics are not effective in more advanced stages of kidney disease. And in fact, the JNC7 hypertension guidelines and the 2021 KDIGO hypertension and chronic kidney disease guidelines recommend use of loop diuretics when the GFR is less than 30. However, this study took patients with GFR less than 30, the mean GFR was about 23, whose blood pressure was not controlled on other medications, and randomized them to either the addition of chlorthalidone or placebo. This study did find chlorthalidone was effective as compared to placebo, with a decrease in blood pressure averaging about 10/4. There are some concerns I have here. First, many patients with these advanced stages of chronic kidney disease are already on a loop diuretic. In this study, about 60% of the patients were on a loop diuretic at baseline. And in general, unless a patient has volume overload that's refractory to the loop diuretic, in which case we often add metolazone, I do not like to combine loop and thiazide diuretics. I find this increases the risk for hypokalemia significantly. as well as potentially affecting the creatinine. Now, this study, about 60% of the patients were on a loop diuretic, and they did find there was a significant incidence of hypokalemia, about 10% in the chlorthalidone group. And there was also a significant incidence of an increase in creatinine of greater than 25%. So about 60% of the patients in the chlorthalidone group who were already on a loop diuretic had an increase in creatinine of greater than 25%. About 20% of the patients who weren't on the diuretic and had chlorthalidone added had an increase in creatinine to this degree. Now, what this study did is they standardized the loop diuretics to either 10 or 20 milligrams of torsemide. So in my opinion, if I have a patient with chronic kidney disease, stage 4, whose blood pressure is not controlled on the regimen and is on a loop diuretic, I would consider one of two things. First of all, if they're not symptomatically volume overloaded on the loop diuretic, I would consider just changing them from the loop diuretic to chlorthalidone and monitoring their volume status and blood pressure prospectively. The other option would be to change the loop diuretic to torsemide, as done in this study, as torsemide has a longer half-life than furosemide, and given this may be more effective in controlling blood pressure. If this is not effective and chlorthalidone needs to be added, I would be very cautious using a dose of 12.5 milligrams only 3 days a week. In fact, this is what the study authors recommended in a reply to a letter to the editor. So that's it. Thanks for watching. If you made it this far, you might as well hit like and subscribe. Leave a comment. What do you think about the use of diuretics, thiazide diuretics? Which is your go-to? And until next time.